Hi, Ryan. I want to move. I can move this on then. Warren and Dixie. Huh? The floor is mine. Oh, that's bad. Warren Dixie, thanks for inviting us, putting this all together. I must say, as an intensivist, so I'm a pediatric intensivist, which means I train to be a pediatrician, and then doubled my training time to be specifically working in intensive care units. So I work with critically ill children, and I'm really impressed by all of you having the bravery to come together, facing even death, or the fear of losing a child, or that moment, and we're often in that moment when family members have what I call the moment of the death of the ideal child, to lose that trajectory that you thought you were going to be on. And that's a time of mourning. And as you put together the disease process that your child is under, start to learn more and more about it, I'm always impressed by family members who coalesce together, gain more information, and share, and gather strength in numbers, which you're doing today. So thanks for letting us be a part of it. I don't have anything to disclose. I do some research a little bit with novel therapeutic devices, et cetera, and I do some consulting for Doctors Without Borders in other countries. All right. Yeah, sorry, I'm blowing it. Anyway, as you've heard over and over again, this is a multifaceted approach. Our team is in charge of really overseeing the multifaceted approach for a disease that definitely manifests throughout the body. Right? We've talked about everything from head to toe, and this disease, or aptitude and smooth muscle illnesses really do manifest in almost every tissue type. And they have a lot of interplay with each other. And my job is to orchestrate a team to try to keep that all in check, to try to address one of those organ systems while keeping in mind that it might affect adversely or potentially beneficially another organ system. We're trying to keep that all in mind. I'm sure you spent a lot of time reading these papers here. Anyway, this is the paper that came out just in 2018, from which a lot of the different organ systems are described by Diana and Patricia. So if I were to ask I run a team of multiple fellows, multiple residents, nurses, medical students. If I were to ask them, where are smooth muscles located? You all know now, after a long, long day and after studying this disease on your own, but I might get some wise punk answer, like, not those smooth muscles. But where are they located? Are they located, oh wait, I'm looking at a different, sorry, hold on, break. Sorry, I have a different one. You don't have to start over, complete it, trust me. Anyway, it's fancier. Anyway, because I also want to make tribute to the fact that it's the SMDS conference now. So there's like some famous people here. Where are smooth muscles located? Arnold, my former governor, I'm really sorry about that. It's not his smooth muscles. Anyway, they're located everywhere, as you've all learned. And I think this slide is really telling for me. As you can see, the smooth muscles are located in all sorts of different organ systems. And a lot of it's connected through this plexus and is moving through the peripheral and central nervous system. So there is some central controller. A lot of things that we give children will affect the brain and the spinal cord and how they communicate with each other. And the smooth muscles, whether it's in the airway, whether it's in the lungs, whether it's in the vasculature, will be affected by that. And we have to keep that in mind. What, of all these systems here, what's the largest organ? What's the largest organ in the body? You didn't think you needed a quiz. Skin. Oh, so skin. And smooth muscle is found in skin in multiple different aspects, right? And sweat glands and the ability for it to have piloerections, or things like Goosebumps, I was hearing something about goosebumps.
No goosebumps.
No goosebumps?
No goosebumps.
All right, so slight lid droop, red eyes, slight, and then no goosebumps, plus, make a diagnosis. So I think sweating, some children sweat a lot. There's lots of differences in terms of how clammy they are, et cetera, and how red they get, how well they tolerate temperature changes, have a lot to do. It's all manifest in the skin. And smooth muscle controls all of that. And if I were to think of the skin as not only a barrier between the outside world and the inside world, it's also and it's also a great regulator of temperature, et cetera, but it's also a great reservoir for blood. So the body does a really good job of keeping blood in that vasculature as well as other vasculature, kind of preserve it for other times. And then when the patient goes through a stressful period, the blood vessels constrict and shunt blood towards important parts. And if that part of your body, that massive organ, and all of its blood vessels are not really communicating with the rest of the body and are not responding to its outside world appropriately, you can see that can get us into trouble when we have other organ systems that are involved. So I have this list of different organ systems, and this also reflects all the different consultations that we might have to utilize in an ICU setting should a child get really sick, because really, like I said, and as we talked about today, smooth muscles are found absolutely everywhere. I like to talk to my team, not from a physiologic standpoint, but from a care standpoint, because we are a multifaceted organization and we're focusing on a single child in the ICU setting. We often have to coordinate between multiple providers to try to address each system in that child. And this is something I call the sphere of care. And I like my fellows to think from the outside in, but also think from the inside out. And what I'm getting at here is I really emphasize with them to think all the way down to the cellular level. We are consummate physiologists. So most of us are in ICU because we had the inability to make a decision. I didn't want to just be an intensivist. I didn't want to be a pulmonologist and study only the lungs. I didn't want to be a cardiologist and study only the heart. I wanted to study everything. And I want my team to also think about, in all those organ systems, what's the most rudimentary part, and it's the mitochondria, which is the ATP, it's the energy forming and developing unit in the cell. Then the cells get together, create tissue, the tissues get together and create organs, and then together it's the body, and they are, that is manifest in that child, and that child is ill, and everything downstream from there, all of the mitochondria, I like my team to think about. And in ACTA 2 and other illnesses, a lot of times that's what we're trying to deal with. How well am I making the mitochondria happy? How are the cells talking with each other? How are the organs conversing with each other? Is it neurologically? Is it hormonally? Is it through blood pressure manifestations, etc.? Is one stealing from the other or not? And I want them to think about that. And then the latter parts of the concentric circles here are talking about the intensive care unit. How is it, or how's the room set up? How's the unit? Is it working together to try to address each child's issue, again, all the way down to the mitochondria? What's the institution doing to help out with this? We're fortunate in the sense that we have every possible consult and consulting service you ever want. And if they don't have the answer, we can move within the periphery, within the city, to several other institutions. And I know that there are also very large organizations within all of your respective locations. And then there's the greater community. It's important for my team to start thinking about rehab, post-ICU stay, how long that will be, and start talking with Elizabeth and Brian about those manifestations. Also about the community at large, like the rest of you. The community that's supporting each other to try to find answers for their children. And what are we learning about? I think, what are we learning about this illness from each other? I feel like even in the last 4 or 5 hours, there's been a few aha moments of connections about what different things have we seen in each other's children, and what were their histories like? What was the narrative like for them? And as those things collate over the course of today and tomorrow and then on, how can that be useful for the next children and for the children now? Without going into massive detail, if a child with ACTA 2 or any kind of smooth muscle illness comes to our ICU, sometimes it's manifest in a cardiopulmonary standpoint, a cardiac aspect and a respiratory aspect. We went through with Bernard Cannon earlier this morning with a lot of the specifics about lung illnesses. Our job, my team's job, is to take machines sort of artificially sustain a lot of those organ systems and keep keeping the mitochondria happy by exchanging carbon dioxide, making sure that the cells get enough sugar, make sure they get enough oxygen, etc. And we use a lot of artificial means to do that, and that's mostly by way of a ventilator system. That's our super subspecialty. And most of our experience has actually been with the Anderson's child, and we've had the privilege of meeting him and spending a significant amount of time. He was admitted to us a year ago tomorrow, right? Yeah, and he stayed with us for 4 months to the day. So we spent a lot of time, learned a lot from him. I know that a lot of my colleagues probably had not heard of ACTA 2, were familiar with smooth muscle diseases, but well, we got schooled really quickly on ACTA 2 from many people. We learned a lot of different things. And here are some lessons. We were able to address his respiratory illnesses by using moderately escalated levels of ventilatory support, both driving pressures, pressure control, volume control, peak, which is the back pressure that we kind of try to keep the very collapsible lungs open with. We used a little bit of oxygen. We even trial nitric oxide, as one is wont to do when you have a child who has saturations that are really low. You tend to escalate toward nitric oxide, recognizing very quickly that this child did not respond to nitric oxide favorably, didn't respond unfavorably either, but after a while we ended up taking it off. It's good not to rely on it if you don't need it. Hi, Chris. You also noticed a lot of arterial pulmonary interactions that were a little bit different. Some children have holes in the hearts, like some type of ASD, BSD, septal defect maybe, not necessarily these children, just in general. And we sometimes see a lot of shunting in the hearts, but we also see a lot of shunting in the lungs themselves. We sort of call it an extracardiac shunt or pulmonary shunt, where blood is moving from the blue side to the red side without picking up oxygen. And we've seen that. Sometimes we see it with lungs collapsing on the ventilator, sometimes we don't. And that was something we noticed very specifically in this case. And I think it was manifest by what Mark Lindsay had talked about, as well as what Bernie Cannon spoke about, which is there's a lot of vascular and smooth muscle interplay that help those two systems communicate with each other, and sometimes they're not communicating very well. I don't mean neurologically by a direct communication, just how well are they matched? And sometimes they're mismatched. When that mismatching occurs, we have a lot of blue blood making it to the other side of the body, and the child really remains hypoxic for some time. And we have to figure out, do I use the ventilator more? Do I use more blood pressure medications? Do I use nitric oxide or not? And it's just good to keep an open mind. Use the tools you have, your experts, to try to answer the questions about whether or not you think, to verify what you think you're seeing. We also noticed very quickly that bronchodilators, as mentioned earlier, did not always work and actually worked deleteriously. I also wonder about HPV, hypoxic pulmonary vasoconstriction in these children. Probably is not really as quick or as manifest as it should be, which is a very natural constriction of the blood vessels in the part of the lung where there's no oxygen. It'll push the blood to the part of the lung that has oxygen in it. And we all have that to some varying degree. And if that's not as reactive as it should be, you're going to have blood moving through the lungs without picking up oxygen, and it remains blue. One thing, it took days to recover, and I want to emphasize here this concept of a very slow wean on support. We were privileged of gaining a lot of information from the family members who had great experience with this patient, and we realized very quickly that making small, slow moves was the only way we're going to make any progress. Don't make any big moves, don't rush. Asking a body system that where different systems are not communicating with each other at a high frequency just try to find that cadence and go with that cadence and make small, slow adjustments. And then also I mentioned here some airway considerations with the ENT, and Chris Hartner is here and we'll talk to you about it next. I want to emphasize that nursing is key for our team. All of our care is really delivered by the nursing staff who are at the bedside and really provide a lot of the continuity because they're the ones who are there pretty consistently over time. We actually have primary nurses that sign up for different patients in their teams and who are all trying to stay on that patient's team for the duration of their stay. Sedation challenges are also another part of the challenges with Active 2 patients. I can't give any general recommendations about here's a list of medications you should use, here's a list of medications you shouldn't use, but because of the amount of vasodilation and the amount of vasoconstriction that's sort of dysfunctional with Active 2, I would be very cautious about about medications that lead to really very massive or extreme vasodilation or opening up the blood vessels. I would think that most anesthesiologists would be a little bit concerned about using some inhaled anesthetics in these cases. We did notice in this case, if I can mention them specifically, is a real extreme reaction to dexmedetomidine, which is Precedex. We're using Precedex a lot more of these two. It's an alpha-2 agonist. We love it. We can give it without worrying too much about a child losing the respiratory drive, actually. This really doesn't hinder that like other medications. But it also has it has a great effect of sedating the child mildly. It also has the side effect, which is usually a problem, of lowering the blood pressure and vasodilating a patient, as well as lowering their heart rates. So the heart rate, blood pressure, vasoconstriction are also not talking to each other as they should. If I add dexmedetomidine or Precedex, we might see some really deleterious effects. In this case, we saw really severe bradycardia, the kind of bradycardia that makes us put that drug on the allergy adverse reaction list and shouldn't get it anymore.
What's the other name that you called it? It's up there.
Oh, Precedex.
Can you spell that?
Precedex.
And just to put it in context with what Brian was telling, this is clonidine, okay? Clonidine is the same alpha-2 agonist central, like mouth. This one is an IV drip. So we were talking about the hypotension concern, the bradycardia. This is what we saw when we put it in the vein, is much faster in effect. And we do have reports from other centers that have had this complication when they were doing sedation for procedures, not just like MRI or like endoscopy and things like that. They have seen the same thing. So it's not just this kiddo, it's probably related to the disease pathophysiology.
And maybe a side note here, probably one of the advantages of Active 2 Alliance and with today is maybe creating a repository of medication adverse reactions so that other family members can go to them and see what they are. Just because I'm not going to publish this necessarily, and it's only going to be discoverable if you happen to know the Andersons and ask questions, etc. There's not enough data for me to publish it. Maybe over time there will be, but I would think that a repository of information by way of an alliance would be actually the best place to put that. Does that make sense?
Yeah.
So that I would sort of think about doing that in this context. Fentanyl, it was very difficult to wean to the point where we were pretty much told ourselves it took so long to wean off an opiate, and that fentanyl is an opiate, sort of a relative of the opiates, of like morphine, etc. That we really did our best to never give it again because it took so long to come off of it. Why? I can't really say, except for, again, everything sort of affects each other. And if a child really gets agitated or warm or cold or hot, or other organ systems are affected by the skin having deleterious effects, you can see how one thing might cascade to another, and we'll look out for that.
What were you saying that they couldn't come off the fentanyl?
Super agitated, absolutely needed the drug back, and so it took a long time to chip away.
And we have to say, it's a drug that makes you constipated right away. If you think about it, it slows down your gut. This is a kid that when anything is happening in his gut, he really gives you a hard time because he's having a hard time. So we don't know if the agitation is because his family is not managing his gas, or it is in the central nervous system. We honestly don't know exactly where this is getting this but it was wild. And that's difficult when you have the lungs struggling or anything else struggling. And if the kid is in the ICU, it's because they're struggling. So we're trying to just be creative from the experience and what we know about the physiology of the disease.
And sort of unrelated to that, we had also noticed during times of illness a lot of lymph drainage problems. So lymph is also controlled by, it also has a smooth muscle component. And so this child would just get really just bloated and full of fluid in the abdomen. It's called ascites. You have to make a fancy word. For lots of fluid, and then it became very difficult for him to move around and feel free. And he was sort of stuck. And that would just add to more of the agitation, which would inhibit us from, or prohibit us from making moves on other things. Ventilatory support, sedation means, etc. Everything's a little connected, right? Propofol, do you guys know propofol? Well, it's infamous now. Michael Jackson, thanks a lot. I love this stuff, it's amazing, it's milky white, you push it, the child goes to sleep immediately, I just love it. I have a small tear every time I see it. However, this child is the only child in my entire career, I'm not that old, but my entire career that got really upset with it. Really agitated, I don't know why, I don't get it, maybe you read about the Michael Jackson report, I don't know. We gave it to him, and I kept escalating and escalating and escalating, just to see, because he was going to go for his first procedure, and I needed him to sleep for it. And he said, no, thank you. And he got really upset. I stopped it, and he actually started laughing and smiling afterwards. So, and then of course, Dixie comes up and says, did you give him propofol? Let him propofol. Anyway, so it's on his medication list now. I don't know where that came from. I don't know if he had felt something really weird about it, and I just couldn't get him to sleep. And I don't know if he just felt something very different and was getting agitated by whatever he was feeling. If anything, it lowered blood pressure, etc., and that was not happening. So I just chalked it up to an odd occurrence and just put it on the list of things I'm not going to do. Other weans of things like Versed, which is also midazolam, or Valiant, diazepam, and methadone took. He had been on them for several months, and it took months to come off. And the Franciscan team knows this, and we would chip away every 4 days, maybe a tiny, minuscule 1% of the dose. It just said, that's what we're going to do. Because every time we tried to escalate it, he said, oh, he's doing great. We tried to escalate, we got in trouble. He would tell us that's a bad idea. Listen. I just wanted to think about the cerebrovascular autoregulation, dysregulation. The brain regulates its blood pressure and its blood flow in a very specific way. The body does everything it can to maintain that flow. And when there's some dysregulation already at baseline, now I'm adding medication that could change that, and I'm on a ventilator that will also change that, because ventilation has a direct correlation with carbon dioxide, and carbon dioxide has a very, very direct correlation with what the blood flow is in the brain. And with all of those, I did my best to try not to alter his ventilatory support by trying to minimize the amount of times we travel, because the travel ventilators are always different. I try to minimize the amount of procedures we had to do outside the ICU, begging our colleagues to please come. And many of our colleagues did come and do bedside procedures where we can maintain the sedation as it was, maybe escalate it a little bit, rather than switching to some other kind of medication on the outside. And Dr. Chris Hartneck, who's here, we'll talk to you in a little bit, is one of the great physicians who came and helped us out by coming to the bedside, doing bedside. Again, nursing, by the way, have I mentioned this? The nurses really help us maintain that continuity. They are the ones who provide us the narrative from day to day. Vascular access is something that comes up in the ICU. No one likes to see their child get poked. It's really painful. One of my earliest jobs out of college was a pediatric phlebotomist. That's all I did. And it made my soul dark for a long time. And I'm still paying for it. But we always try to balance the benefits of reducing pokes and trauma with having some access if we need to do it for a period of time, while also trying to remove any central lines to reduce the potential for clot formation or thrombi, because these children, because of their tortuous vessels and their flow, tend to develop clots, and of course infection risk, any kind of vascular injury as well. So we talk about this all the time with any patient, but especially these patients will it elevates the conversation. It's important for me to talk to my team about downstream effects. Whatever you're going to do on this child, no matter what they have, but again, augmented by ACTA2, a patient with smooth muscle dysfunction, what you do on one level for one organ system might affect another one. And just to think about that. We have used muscle relaxants on these patients. It doesn't seem right? Why are we muscle relaxing a patient who has smooth muscle dysfunction? But it's really two different worlds. The skeletal muscle that I need to relax and the diaphragmatic muscle that I need to relax are regulated by a completely different system. It's about a nicotinic system. And the smooth muscle system is regulated with a muscarinic system. That's a pop quiz question for my fellows. The muscle relaxants we use only really paralyze, I don't like to use that word, but relax the muscle that are skeletal, the voluntary ones. Like, even though we breathe sort of involuntarily, but we can sort of change it a bit. I can relax that muscle, I can relax the movement of a patient so that procedures and travel can be relatively safer. One, two, that the ventilator, if it's working at an elevated level, can really work for the child's benefit. It should not manifest in the smooth muscles. That said, we're also usually giving sedatives at the same time, which do change how the smooth muscles work, so it's hard to know. Again, I mentioned autoregulation of the vasculature, being mindful of any vascular events, insufficiencies that might lead to DVTs like thrombi formation, aneurysms, poor vascular tone or response. And if you're fully sedated and muscle relaxed, we encourage some type of CNS monitoring, maybe like with an EEG, etc., especially for children who are predisposed to some vascular injury in the brain. And again, always look for latent organ effects, and always balance recovery and convalescence, necessary interventions and triggering decompensation. There are times that we say, well, maybe we should move ahead with this or include this, but we would hold off in case we were in a good phase and we're making some recovery. You have to make sure that's definitely a vital thing you want to introduce. Nursing again. I think something that our team, that all of you have probably worked on and maybe struggled with, and we as the medical community probably can always do a better job doing, is listening to families. Who better in the ACTA2 community knows the patient than the parents? It just doesn't happen. Maybe a few investigators in this room, but the families know the best. So when the Andersons came to us and provide us with information from their child, it's really vital to listen, and it really helps us move forward. So terms like, well, this is what he does, or this is what he did last time, or this is not, or for any of your patients, I really think the physician should spend a significant amount of energy listening. This is really not her. This is not, she's off. This is not quite right. She's not quite back to her baseline. Last time we did this, last time we gave this drug, she did this, right? There's this, you all might be familiar with some of these narratives, and it's really important to have those and try to offer those to physicians, and hopefully they're listening. I would prefer if we approach this differently, because I'm worried because of XYZ I've heard from the ACTA2 Alliance, or this happened to our patient that we know, etc. Or would you consider a slightly different approach? These days, I think it should be an open conversation. Yes, we have years of training, etc., but I don't have years of training with ACTA2 patients, I'll be honest, right? So even though I work in a place where I get a lot of academic input every day, I still think there's so much out there, and you all have such fantastic expertise, and you know your children, it should be a conversation. So I ask, who's your advocate? When I think about the sphere of care with my team, I start to ask, I'm starting to think of these ways for the community with patients or children who have chronic illnesses. Who's the advocate? Is it you? Is it ACTA2 Alliance? Is it someone within your care team? Maybe I did how to try to work towards identifying who that advocate is. Coordinating care is a really big part of the ICU management, right? It's not just multi-organ dysfunction, but I need to actually coordinate the care between GI, derm, ophtho, et cetera, as you can see there, and then coordinate with family members and having frequent family meetings and discussing where are we with this organ system, where are we with this organ system, what's our next move that's important. We also are often the context in which the hospital, families, and providers feel most comfortable starting novel therapies. So sometimes certain providers just don't feel comfortable starting losartan without being in the hospital. A lot of times when we start something very novel, like super high nitric oxide for other disease states, we'll do it in the ICU setting first so that people feel comfortable, and then the floor will feel comfortable, and then the rest of the provider levels will feel comfortable. So we start, and acetylcysteine and vitamin A and losartan are not necessarily things that we expect there to be any adverse events, but because the child is already in the PICU, we actually started them there, of course. And then I also emphasize early preparation. If there's an opportunity for a family member, the Active Tool Alliance, or an outside provider to talk to the next level of hospital or a hospital care, is to start the conversation really as early as possible. I looked back and our admission note for this patient was started about 3 weeks earlier, which means we had been in conversation with the family, with the providers, where this patient came from a good 4+ weeks earlier. And Patty Mussolino's team was coordinating already with Mark and all the other Active 2 experts, and then actually sitting down with the ICU team about this is what we anticipate to see, and this is why this patient's coming here. I can't emphasize that enough. And if you're not seeing it on your end, ask someone to help advocate for you so that happens. I think it really helps if the receiving team knows what's happening.
And the experience so far is teams anywhere in the country have been really thirsty to talk to a multidisciplinary team or a critical. When they're really sick, they struggle. And they struggle, they get stressed, you get stressed, the trust is broken. So you really want to get your advocates quickly, early on in the picture. So they can start talking and saying and sharing. We literally are sharing experiences. This is not evidence-based medicine because we don't have enough patients to do the clinical trial for many of the things. But there are concepts of, you saw the time you spent today thinking about smooth muscle cells. That takes a lot of time and work, and this is so rare that we cannot expect any physician or any specialty to have done this exercise before they met you. But you've done it. So get your advocates, as Brian is saying, to get in contact and do it from the very, very beginning. So they have been very receptive. I have to say, I haven't had a doc where the family said, hey, why don't you talk to the people that saw my patient, my kid? And I get Mark and Kina and Ryan and whomever, because it's not maybe in what I do, but I will get anybody that can help that team work out the things and the questions that they have. So do that. This works, at least in my experience, is not intrusive. And their personalities, but we worked it out.
And we're happy to have conversations with providers in your corners to say we've had experiences with these children in these states. Let's have a conversation. That's fine with us. So in that context, I'd say, who's your camp counselor? Who's rallying the troops? Who's telling them where to go? Who's kind of putting it all together? There's also, specific to these children, as you well know, are environmental triggers, both temperatures. Yeah, sorry, if anybody gets the reference, thank you very much. Environmental triggers, be careful, be considerate of noise and light and stimulants. Be careful of lights, noise, and then tactile stimulation, which it can be very beneficial, but can also be very negative if the patient can't see me come in the room or doesn't hear me without touching the child and startling them, can actually trigger an event. And so be careful about that. So we had to go through some innovations, environmental considerations like putting in fans. These children get really hot, cold, they need some sweat, they get really clammy. We don't usually have fans in the ICU, but we have fans for this particular patient. Dark rooms, sunglasses, tactile auditory stimulation that's beneficial. This child has certain things he really likes. I've never seen a child with a Mylar balloon. If you're a hospital, you do it. He'll just play with it for hours. It's fantastic. It gives me such joy to see it. Body wraps, harnesses, and orthotics. This child also has Eagle-Barrett syndrome, so he's a little bit softer in the middle, like me. But he's a little softer in the middle and requires some tucking in. And our model shop guys got super excited about what they could make for him that was adjustable, that allowed him to move, etc. Of course, involving child life and developing some type of schedule. It's not just the ICU schedule. Once the child is out of the woods from a pathophysiology standpoint, where the schedule is dictated by the disease, is to also consider creating some type of wake-night cycle, activity cycle for them that has some emulation of a normal circadian rhythm. And then plan maybe to be in the unit where they can have social interaction, have high level of surveillance without, at the same time minimizing noise if it's possible. ICU, we've done decibel studies in the ICU and it's really high. And so try to think about that and take that into consideration. So I asked, who's your innovator? Who on your team? Is it you? Is that the two alliance? Who's your innovator? Who's helping you build a new thought process, a new direction, a new approach to XYZ? Again, a big part of a coordination of multiple providers, sometimes it falls on the shoulders of the parents. For our team, the nursing staff provides a lot of that continuity. We do have nurses that sign up to be the primary for these patients, like 2 or 3 nurses for children we know will be in the unit for extended periods of time. From the physician side, we don't do that very well. It's hard to have a single physician that's in the unit all the time. We rotate quite frequently. But for certain patients that might come in and out, it might be something novel to introduce is having 2 or 3 physicians who really know the patient well from the beginning and can act as a sounding board, et cetera, and help coordinate. So I'd ask, who's your quarterback? We know who our quarterback is here in Boston. I'm really sorry about that. But who's helping guide the team? Who's helping direct? Who's trying to create continuity? So my overall thoughts are for providers to keep an open mind, to listen to the families. They have the greatest amount of patient-specific data and history, coordinate between multiple services, try to coordinate as much as possible, coordinate family meetings as much as needed, and then keep track of the patient-specific reactions to maneuvers, to travel, to medications, to sedation, to PEEP, things on the ventilator, effectiveness of specific medications like nitric oxide, et cetera, and try to create a narrative for that patient so that no one later on should attempt them again if it's deleterious. And I would identify for yourselves who's your advocate, who's your camp counselor, who's your innovator, who's your quarterback, and go slow. No big, fast moves unless you need to, but try to be slow, try to match the cadence of the disease and not rock the boat. So, questions? Or whatever the questions are.
We're going to do questions now for
Okay.
you. Thank you.
All right, so Dr. Carroll, this is for you. So someone in England would like to know, did you say that a nasal anesthetic presents more risk than an injected one?
The inhaled anesthetics are notorious for leading to really dramatic vasodilatation and dropping of blood pressure. We like it because sometimes the blood vessel pops up and it's easier to get an IV. But I think a lot of cardiac anesthesiologists and a lot of providers would be really reluctant to use the isoflurane, sevoflurane group, or the fluorine group. I would check with your anesthesiologist to see if they would be, what their concern level would be. But I personally would be nervous, so I would probably use IV. But we're really more critical care and ongoing drip sedation, not acute sedation for anesthesia. But I'd be reluctant.